Okay, so we are live now. We can start.
Yes, warm welcome to the 39th live webinar of Pediatric Orthopaedic Society of India. The topic of today's webinar is changing concepts in the management of upper extremity problem in children. We are really fortunate to have 5 experts on the topic. The 3 are from USA, that's Scott Kozin, then Zlotolow, and Kevin Little. Atul, Bhaskar, and Sandeep are our own POSI members. To give you the brief introduction about the faculties of today's program, the Scott Kozin has already been once to our webinar. Last year in June, he shared his experience on the brachial plexus bird palsy, and that was a wonderful talk. So he is the chief of staff at Shriners Hospital for Children at Philadelphia. He was a past president of American Society for Surgery of the Hand. He is world renowned for the first case of a bilateral hand transplant on a boy called Zion. Now already 6 years have passed and that boy is doing wonderful. He has more than 100 peer-reviewed articles. And when he was a president of American Society for Surgery of the Hand in 2014, he started an ultra-sting program called Touching Hands. And by that, experts from developed countries, they visit various countries like Ghana and the African countries, and they carried out surgical work over there. He has also authored a book, editor of the book, The Pediatric Upper Extremity, and the second faculty of the program, Dan, is also the co-editor of that book. So Dan and Scott, they work together at the Shriner Hospital. But in addition to that, Dan is also attached to the Shriner Hospital of Greenville and Hospital for Special Surgery in New York. He was also a team leader in the case which I described, the first bilateral hand transplant. In addition to that, he is very active in various clubs related to the upper extremity problems. That's a Menace Club, the Plexus Nexus, and the Pediatric Hand Society, which is relatively a new society and which focus on the problems of upper extremity in children. Again, very active in the Touching Hand program, and he has visited Havana, Cuba, Rwanda, and Kigali. He has also authored a wonderful book, which is a small book on the splinting and casting for the upper extremity. And everyone who was interested in this area should read this book. It's a very lucid, very small, very to-the-point book. The third speaker, Kevin Little, again, a very popular name in India because he visits India very frequently. And he has been a part of various POSICONs in last 6 years. He works at Children's Hospital of Cincinnati, where another POSI member and the POSI friend, Sheetal, is working. Again, very active at the Touching Hand projects. He has visited Ahmedabad, particularly at the Polio Foundation, as a part of this program. He has also visited Honduras, St. Vincent, and Grenadines for the same program. In addition to that, he has a keen interest and in the sports, and he is working as a coach for his kids sports team. So for him, there is a life beyond orthopedics, and I really appreciate that. The 2 Indian experts, actually, they don't need introduction because they are very renowned in India. But for our foreign faculty, I will give their brief introduction. Atul Bhaskar is practicing at Mumbai, at Bombay Hospital and another private clinic in Andheri. He is a director of motion analysis laboratory in Mumbai. His main area of interest are trauma, osteogenesis imperfecta, relapsed clubfoot, and cerebral palsy. Again, I am very glad to say that he has written a book, Pediatric Fracture Management, and again that book has been translated into Arabic language, which is again a pride moment for us. Sandeep Patwardhan does not need any introduction because he is a secretary of Pediatric Orthopaedic Society, but he is a professor of orthopedics at Sun City Institute and Institute of Rehabilitation, and he is a founder of International Federation for Fractures in Children Symposium. So with that short introduction, before I hand over, I would like to tell you about the format of this webinar. We have not a big lectures, but we have 6 small talks on a very important topics for our practice. So I'm not going to describe who is going to speak on which topic, but we will have 10 to 12 minutes talk on these 6 topics. If you have a question, you can WhatsApp your question on 98230-63989. That's Sandeep's WhatsApp number. The last few words about the upcoming webinar. We have out of the box webinar on the next month, that's 10th June, and that is about improving the patient satisfaction. This program was actually on the 10th May, but we have to shift it to 10th June. And Dr. Helen Reyes, who is an author and the TEDx speaker from Harvard Medical School, she's going to speak on this topic. And on the 22nd June, we have another webinar on split capital femoral epiphysis. And again, we have an expert faculty from Europe. So with that small words about Pediatric Orthopaedic Society and our activities, I now request Kevin to share his screen and start his first talk. Thank you. Over to you, Kevin.
All right, can you hear me now? My screen froze for a minute. Good, okay. I'm going to share my screen now, talking about scaphoid fractures. So once again, thank you for having me back. I wish I could have come this January back to Ahmedabad, but hopefully we'll be back next year. I don't have any disclosures, but we do have an excellent book about this topic through the ASSH. And I know the Pediatric Orthopaedic Society, or the Hand Society of India, I think, is one of our featured guests for the ASSH meeting. So hopefully we can see some of you guys there. I do wish everyone safety and health. I hear things are getting a little bit better, but you've had a typhoon and a COVID disaster in India the last few weeks. So I send you my best regards and do hope to come back. I think it does help to talk a little bit about a case and think about scaphoids in this way. This is an 18-year-old football player who had an injury about a year ago. He played through it, didn't think much of it. I was never evaluated by ortho. And then once the season was over, he stopped having pain. And then the next season came around and started hurting again. Mom was a radiology tech, took an x-ray, and then showed up in my clinic. So thinking about the scaphoid is a cartilaginous bone starting off in the wrist. It doesn't really ossify until late, usually around 4 to 5. And then it ossifies distally to proximally. So your normal scapholunate interval starts off wide and eventually normalizes by 12 to 16 years of age. The scaphoid bone is in the proximal row, but it really links the proximal and distal rows. And if you think about it that way, you know, motion the wrist side to side, up and down is linked by the scaphoid, and that's how scaphoid fractures will fall apart. So if you can think of it that way, then you can think of how to treat these and get them to heal. The ligamentous attachments are intrinsic ligaments, as there are no muscle attachments to the scaphoid. The most important is the dorsal scapholunate and then the volar and central membranous portions. Extrinsically, there are also volar ligaments, the radius scaphocapitate, long radiolunate, short radiolunate, holding the wrist together, and then the dorsal on the right here, looking at dorsal intercarpal and dorsal radiocarpal ligaments. In addition, the vascular supply of the scaphoid is somewhat tenuous, going from distal to proximal with a volar and a dorsal contribution. The dorsal contribution seems to have more contribution to the proximal pole, with a single blood supply to that area leading to high rates of vascular compromise in proximal pole fractures. Scaphoid fractures are common wrist injuries, about 10% of all wrist injuries, but more than 60 to 70% of all carpal fractures being the most common thing that we see. They are difficult to diagnose based on the shape of the scaphoid, and delayed healing is frequent based on the blood supply. So our goal is to figure out why these happen and diagnose them appropriately and then treat them the same way. The mechanism is typically a fallen outstretched hand, less frequently a direct blow. Typically it involves a hyperextension where the proximal row and distal row are hyperextended on each other, and that cracks the scaphoid in the waist. The diagnosis is made by a compilation of the history and the physical exam. In my hands, the physical exam findings that are key are looking for dorsal radial swelling, limited range of motion of the wrist, especially in extension and radial deviation, tenderness to palpation in the snuff box, the distal or proximal pole, and most consistent is pain with radial deviation of the wrist. If you radially deviate the wrist, you are flexing the scaphoid and compressing the fracture and causing pain. If these are suspicious, then radiographic evaluation is necessary. Typically a scaphoid series, taking a PA and a lateral. We do a scaphoid view that involves pronation and ulnar deviation with a PA view. This works really well to extend the scaphoid and try and evaluate it in the best way. And then the way we can identify the different fracture patterns, which are either stable, like tubercle fractures or incomplete fractures, or unstable fractures, where oblique waist or proximal fractures. Plain radiographs are only about 70% sensitive for fractures at presentation, with a slight increase at 14 days. And it can take up to 6 weeks for plain radiographs to show evidence of an occult fracture. So advanced imaging is often required. The sensitivity and specificity of these advanced imaging techniques are shown here. In general, though, a CT is more important for displacement and an MRI for occult fractures. So if I suspect someone of a scaphoid injury and I want to get them back to sports quickly, an MRI would be the best way to diagnose them appropriately. The treatment of these is based really on a number of factors, including their age, their location, the stability of the fracture, and patient factors like compliance. Our goal, however, is to prevent non-union. We know these fractures take a long time to heal and can develop arthritis. In adults, this is radiocarpal arthritis in 5 to 10 years and pancarpal arthritis in 10 years. We do not have enough data in pediatric scaphoid fractures to know if this is the same, but we know that non-union can cause pain and problems, especially with displacement of more than 1 millimeter, proximal pole fractures with necrosis in kids who smoke, or even vertical oblique fracture fragments. So in kids versus adults, in kids, cast treatment has a higher, success rate because there's a higher incidence of distal pole fractures, which heal better. There's a great ability to heal. There's better blood supply, and these are more often stable fractures with less high energy injury mechanisms. However, there's a lot of debate with long and short arm casts and thumb spica versus regular casts. I think some better data is showing that regular casts are better with faster healing than thumb spica casts. And so I've switched to that for all scaphoid fractures, unless I'm concerned that having their thumb free will allow the patient to go back to things faster. Golson had a very good article 10 years ago now, looking at scaphoid fractures and contemporary techniques. Looking at these, we do know that there is a very high success rate for all non-displaced fractures and any displaced distal pole fractures. However, displaced waist and proximal pole fractures have a low rate of healing and should be considered for surgery. In the chronic case, it's the other way around, where only non-displaced distal pole fractures have a high rate of healing, and every other fracture has a less than 50% chance of healing with just closed treatment. And so in these patients, open surgery is indicated. In addition, unstable fracture patterns with more than 1 millimeter displacement and some collapse, like greater than 60 degrees scaphoid angle, or large intra-articular distal pole fractures may require surgical fixation in order to get them to heal. Operative fixation is typically performed for distal pole fractures that are large, intra-articular, or chronic and displaced, or in waist fractures with displacement, angulation, or humpback deformity. Or in proximal pole fractures, operative fixation should be done for all proximal pole fractures in order to get healing reliably. Typically, headless compression screws or headed screws that are small are used for fractures with large fragments. However, with small fragments and in pediatric patients with large cartilaginous pieces, perhaps pins are necessary in some of these instances. My preferred technique for a distal pole or a waist fracture is a volar technique. This can be done percutaneously for minimally displaced fractures, or it can be done slightly open, where a small incision is made around the FCR. The fracture identified under the radioscaphocapitate ligament reduced, and a headless compression screw is placed in a retrograde fashion. This then, as shown here, stabilizes the fracture in an excellent position. You can take good x-rays with this position. And it does help to hyperextend the wrist over a bolster when you're putting these screws in to get the trajectory between the scaphoid and the trapezium and trapezoid joints. The dorsal technique is my preferred technique for proximal pole fractures or proximal waist fractures, where you can make a small incision in the joint, you can see the fracture, reduce it, and hold it anatomically still while you fix it from a proximal to distal. I think you get a little bit better angle of the fracture this way than you do from a volar approach. However, you do not get good fixation of the distal pole. Arthroscopic assisted fractures fixation has been additionally utilized in many instances. However, I do not use this typically, as I feel like I can get a good reduction with a minimally invasive incision. On the other hand, scaphoid non-unions, which used to be about half of all scaphoid presentations, are common as well. These are fractures that have not healed by 6 months, often due to delayed presentation or significant displacement, or perhaps due to proximal pole AVN. As you see here, a scaphoid non-union evaluation typically involves standard radiographs, then a CT scan, especially for waist fractures and distal pole fractures to evaluate displacement, as well as the non-union. An MRI is useful for proximal pole fractures to assess for avascular necrosis, as you see here. The initial technique described was a volar inlay graft with a partial release of the radioscaphoid ligament, reduction of the fracture via hyperextension. An integralary cortical strut graft inlay was placed, and then the patient was casted for up to 12 weeks to allow this to heal. Fixation was not required due to the strut technique. However, it was somewhat futzy, and the preferred technique now is a headless compression screw, where you do the same technique, you extend the wrist, you scrape out the non-union, you pack corticocancellous bone graft from the distal radius, which is my preferred area. You can take a small chunk from the roller radial corner, which gives you tricortical support. You can pack some cancellous graft into there, and you put a screw across it. This generally heals really well. I would say in my hands, about 90% heal within 6 weeks. Vascular bone graft can be used, not typically indicated in patients under 21. I've had multiple patients with AVN of the proximal pole heal just with creeping substitution and distal radius cancellous bone graft. However, for failed bone grafting procedures or revision scaphoid fixation, vascularized bone graft can be performed. I typically would use the second intercompartmental supraretinacular artery. This can be then rotated around to fit anywhere, even for a humpback collapse deformity, as I have seen. There are other different options. I know Dr. Kozin and Dr. Zlotolow have other options that they prefer, using different branches and different arterial supplies. And these work really well for these chronic cases. So back to our case, this 18-year-old football player was seen, had a proximal pole fracture. MRI showed slight AVN, but he was treated with simple open rectal internal fixation with some distal radius bone graft. And you can see healing on the CT scan at 10 weeks postoperatively and full return to function without any pain or complications. Here's his healed CT scan. So in summary, scaphoid fractures are common. There are many fracture patterns that are amenable to closed treatment, which I prefer to now do a below elbow, no thumb spica cast. Proximal pole and displaced waist fractures should be fixed, and healing is reliable in most pediatric patients without vascularized bone graft, unless revision fixation is necessary or other information indicates its use. Thank you very much for your time. I look forward to questions and comments.
Yes, Kevin, I have a question. Like, see, what is the change in the trend? Like, is it the same for last decade, or there is a change which you are facing or which you are seeing in the practice?
Well, we are seeing over time more higher energy injuries in kids, so more displaced fractures and more indication for initial surgical fixation. We are also seeing less chronic non-unions. I think we're getting better at diagnosing them or treating them appropriately. And so we see fewer of those over time. So we're being better at treating patients appropriately. I think the other thing that we're trying to do is more early diagnosis for occult fractures. So getting MRI early can be helpful for that diagnosis. We've also noticed that certain institutions have a limited scaphoid protocol that you can use. That's a very quick and easy 2 or 3 image techniques in MRI just to diagnose scaphoid fracture or not. So those are things that we're seeing. So we're probably fixing
Kevin,
more
there's a
scaphoid than we
question.
used to. Yes, Sandeep.
Okay. Yeah, there's a question for you. Do you correct the DC deformity when you are doing non-unions? And what
Correct,
are the
I
tips
do.
to correct it intra-op?
So the tips that I use, one, you hyperextend the wrist over a bolster. And then when you are freeing up the humpback deformity and cleaning out the fracture gap by hyperextending, you can reduce the humpback deformity, which then reduces the dizzy deformity. The other thing you can do is if you're having trouble, you can reduce the lunate into its anatomic position with extension, then put a pin in dorsally through the radius into the lunate to hold the lunate still. And then when you hyperextend, you will correct the lunate deformity at that point. And then by putting the intercalary graft in and stabilizing the scaphoid with your screw, you will maintain that reduction of dizzy deformity.
Okay, let's go to the second talk, Scott. Yep. Thank you, Kevin.
Thank you, Darren.
Darren, can you see my slides?
Yes.
Okay. First and foremost, I just want to echo what Kevin said about everyone's safety over in India. Our prayers are with you guys, and we really hope all is well. It feels nice to turn the corner here, and I hope you will turn the corner soon. So I'm going to speak about medial epicondyle fracture management and kind of what's new and what we do. And I'm mainly going to focus on operative indications. So I'm going to discuss operative indications, the way that Dan and I fix them now, and potential complications from medial epicondyle fractures. So there are certain definite indications. So for us, if there's an elbow dislocation, that's become a definite indication. Clearly, an elbow dislocation and a medial epicondyle that's incarcerated in the joint is truly a definite, because you have to get it out of the joint. And we teach our residents and fellows the Where's Waldo technique, meaning that when you have a pediatric elbow fracture dislocation, you need to find Waldo. And Waldo is the medial epicondyle. So let me show you an example. This is a child who's on the beams. She misses the top beam and dislocates her left elbow. So I'm going to show you again in slow motion. This is the mechanism that you see, mainly gymnastics or mainly some other type of athletic endeavor. So she misses the bottom bar and then subsequently dislocates her left elbow, right? And that is an indication for us to fix the medial epicondyle, whether it's in the joint or not. But here's another example. A 14-year-old male fell rollerblading. So there's Where's Waldo. So if you look at the left part of the slide, you see a posterior lateral dislocation in the elbow. There's the medial epicondyle. And that has the propensity to go back into the joint and be a block to reduction. Now, it's not always as obvious as one would think, meaning the joint's not jacked wide open, but you need to find that medial epicondyle. So this underwent a closed reduction, and there's Waldo. So you can see on a lateral x-ray that Waldo or the medial epicondyle is within the joint. Now, the referring orthopedic surgeon wasn't quite sure, so he obtained the CT scan, and the CT scan demonstrates that it's in the joint. But you can see how that could be missed because it's not really cranked open, but it's clearly in the joint and you have to be able to find him. How do we fix that? We're going to pull the epicondyle out of the joint and we're going to fix it with a single cannulated screw. So I'm going to talk to you a little bit about how we fix it, but this is our preferred technique. This is a single cannulated screw that crosses the epicondyle, across the fracture site, and runs up the medial column like you see here. We do not try and obtain bicortical fixation. It's unnecessary. And that to me is a home run. So what else can be stuck in the joint? So obviously there's other things that can be stuck in the joint that can impede reduction. They need to be removed. So let me show you an example. This is a group of us when I visit the Navy. I operate with the Navy guys once a year in San Diego, pre-pandemic, obviously. This is the team. And here's Alyssa. She's a 7-year-old female who was visiting her dad at Camp Lejeune in California. She fell at the trampoline park. She dislocated her right elbow. So she underwent attempted reduction in the emergency room that was deemed unsuccessful, and then she's referred for an evaluation. But everybody knows when you get these referrals, you just think they didn't pull hard enough, because we're orthopedic surgeons and we're better than the last orthopedic surgeon that we saw. So we saw her. Her examination was limited by pain and compliance. The compartments were soft. The dictation by the resident indicates that she, Alyssa, can fire the ulnar and PIN motor groups, but seems unable to fire the AIN motor groups or from the median nerve. Here's her initial x-rays. Again, everybody sees Waldo in the back, the epicondyle, but that's not the impeding process, because after the attempted reduction, you can see there's no Waldo in the joint. But what you do see is the joint is widened. So the question is, thoughts, can we do better? So we thought initially that we'd just take Alyssa to the operating room and do a closed reduction, but yet lo and behold, our closed reduction was unsuccessful also. So you can see from this lateral x-ray, you see the epicondyle in the back, clearly the ulnar humeral joint is widened. So you have to put your thinking cap on and think, what else could be impeding reduction? Now what? We tend to do the surgery in a lateral decubitus position, medial exposure, and what was in the joint? Median nerve. So Dan and I have seen this a few times now, where the median nerve gets pinched into the joint, it kind of goes in the joint and then back out of the joint. And this is a great line from the dictation of the resident. At this point, we requested med photo for imaging to be obtained, showing this phenomenon. It's not really a phenomenon, but it gets a sense of how surprised we were that it was the median nerve that was inside the joint. So if you can't get the reduction and it has that mushy endpoint, don't keep pushing it. You need to be concerned that something's in the joint, like the median nerve or like the medial epicondyle. Here's the exposure. So you see the arm with the hand to the right and the shoulder to the left. This child's in the lateral decubitus position, which we'll talk about a little bit later. Ulnar nerve's isolated first. The median nerve is going to be down at the bottom. And there's the median nerve going inside the ulnar humeral joint and then coming back out. Because once the medial epicondyle is pulled off, the nerve can migrate posterior. That posterior migration allows the median nerve, which is no longer blocked by the epicondyle, to enter the ulnar humeral joint. The median nerve was intact but battered. We did a reduction and we fixed it. In this case, there's the ulnar nerve and there's the screw fixation. Here's her x-rays after fixation. Here's her remote 6-month follow-up. I came back home to operate in Philadelphia, but her follow-up range of motion shows good elbow range of motion. That's nearly full. Her pronation supination is full, and her median nerve had recovered. And there are her x-rays. So you can see that's a good one. That's a good patient to save, and it's a good way to disimpact or disentrap the median nerve. And that also is we'll give it a gold score on that. Now, what about displacement? There's a lot of people that talk about, oh, I operate on medial epicondyles if they're 3 millimeters displaced or 5 millimeters or 15 millimeters or a centimeter or some number, right? Well, that's been shown that number is unreliable. So the question is, can you measure displacement? This is one of my favorite articles by Eric Edmonds. And what he did is he took x-rays that looked to be non-displaced and then did CT analysis. And what he showed, an x-ray can look like this from a medial epicondyle fracture, but a CT scan can show it elevated and up. So all these numbers that we talked about before were thrown out of the window with one fell swoop by Eric Edmonds. So the question is, how did he bury the sacred cow? And what he showed was that minimally displaced or non-displaced fractures by x-ray can be displaced as much as a centimeter. So we no longer rely on displacement as a reason to fix the fracture. We rely on stability, number one. Number two, if there is an elbow dislocation. And number three, if it's incarcerated in the joint. So there is no consensus anymore on displacement. How do we fix it? This is Elam. He's a 16-year-old Amish male who fell off a front loader 2 weeks ago. Since I'm a city folk, I didn't know what a front loader was. Maybe Kevin has a better idea than me, so I had to look it up. But a front loader is in the bottom right. He had marked swelling. He was treated in the splint, and then he was referred. Here's his range of motion, which is limited, a fair amount of ecchymosis. His median, radial, and ulnar nerve were intact. And here's his image. So you can see on the image on the left that that's a very displaced medial epicondyle fracture. And with that epicondyle fracture, that's going to take off the ligament, and that's going to create instability. So then he was examined with stress x-rays in the operating room, and you can see the medial joint line opening, which is indicative that the ligament's attached to that piece, and it's indicative that you need to fix this. So how do we fix it? Our preferred is a cannulated screw, like I talked about before. From a pearl, I think this is a much easier operation lateral or prone. Why? Because when you're supine, your elbow's typically in valgus, which is going to displace your fracture. When you're prone or when you're lateral, you put the arm in varus, which makes it easier to fix. And you need to avoid the ulnar nerve. For us in Philadelphia, our anesthesiologists do a lot of spine surgery, so they're comfortable going either lateral or prone. It doesn't make any difference. So here's Elam. Here's his lateral approach. And you can see in the lateral approach, when you bring the arm behind the back, you're putting the elbow in relative varus, which is taking all the stress off the fracture site. The ulnar nerve is exposed. The MAB is protected. And then you want to fix the fracture. We tend to use a double skin hook to clean out the fracture. And then we're going to fix it with a cannulated screw here. And there's our fixation. One point about cannulated screws that Dan and I harp upon is the wire that goes in should not be a threaded wire. Often the set comes with a threaded wire, but a threaded wire will wrap up a nerve. We switch it out for a smooth wire, which has much less potential for damaging a nerve. Here's his intraoperative fluoroscopy. And here he is at 2-week follow-up. I wouldn't say he looked happy, but that's about as happy as he can look. And here's just a little bit of residual stiffness. It does take them a little bit of time to get terminal elbow extension back. Pronation, supination, and flexion come back much quicker. And here he is all done. Now, one of the complications I just want to emphasize is chronic instability. And this is Elena, who's a 13-year-old gymnast who dislocated her elbow about a year ago. And her main complaint was she couldn't bear weight. So she's a gymnast, and every time she bear weight, she developed pain in the elbow. Her dad is actually a radiologist, so she came with a boatload of imaging studies. But if you look at the x-rays carefully, the plane films, what you see is the epicondyle has displaced down to the joint line. So you can imagine that if that piece is displaced so distal, the ligament cannot be competent. It has to be loose, which creates valgus instability. Here's additional advanced imaging studies. And again, you can see that piece all the way down by the joint line, which is going to make that ligament lax, which is going to create valgus instability. She's a year out. In our practice, there's no way that you're going to be able to put that piece of bone back where it belongs and create competency in the lateral collateral, in the medial collateral ligament. Evaluation is interesting. You know, in muscular kids, I think we're not good about detecting valgus instability. So Dan and I both examined her along with our fellow. We thought she was pretty stable, but it didn't make any sense that she was stable. So we brought her to the operating room and she's valgusly unstable. You can see here. So there's no competency in that ligament on the medial side. How do we fix it? We want to reconstruct the ligament. Now, it's much more difficult than your typical Tommy John type operation because the medial epicondyle is present. If the epicondyle is out of the way, we just ignore it. If it's in the way, we get rid of it and then reconstruct the ligament. So here's the medial approach. That's the ulnar nerve. That's the ulnar nerve through the flexor carpi ulnaris. And then we're going to reconstruct the ligament. The other difference in kids is often the palmaris longus is too small to reconstruct the ligament, and you may have to use the flexor carpi radialis. And here's bone tumbles. Again, not your standard Tommy John because there's no epicondyle to dock the ligament in proximal. But here's our reconstruction, our standard FCR reconstruction. And here's her outcome, and she is stable. So that's the way we restore stability if there's instability following a medial epicondyle fracture. With that, I will end my talk, and I thank you for your time, and I'm available for any questions, and I'll be back later with a talk on compartment syndrome.
Yes, thank you, Scott. Sandeep, any questions from audience?
Yeah, no questions right now from audience as of now, but I have a question. So Scott, great talk. Just a question there. In India, we get a lot of delayed presentations. A lot of kids don't come on day one. They would come probably miss somewhere in the peripheral regions in the rural parts of India, and they have been treated either by a bone setter and they have some early myositis. Now, in presence of myositis with history of massage with a medial epicondyle which is displaced, as you rightly said, you don't know, you cannot quantify displacement. So with that scenario, how do you examine for instability? How do you know that this is unstable? Because you said one of the indications is an instability.
Yeah, I think it's a great question, especially we'll talk a little bit about the bone centers on the compartment syndrome talk, but I think I don't think you can always detect in the office. I think you're going to have to give some sedation and then look under fluoroscopy or look under imaging. Dan could talk about it too. We've learned that both posterior lateral or valgus instability is very difficult to test in a muscular individual or in an apprehensive child. So we would examine that child under sedation or anesthesia and then make a decision about whether or not we should fix the fracture. Good question.
So do you use an arthrogram? Because sometimes when I've done it, I put some dye which shows or quantifies the amount of medial opening.
Yeah, exactly. We have a very, that's a good point. We have a very low threshold for arthrogram. We love arthrogram. The thing, we do the arthrogram from the posterior portal that Kevin's partner, Roger Cornwall, showed us. It's a much easier way than trying to come from the lateral. So you just stick some dye in the back, some dilute dye, and then move it around. That's a great point. Arthrogram for sure.
Great, thank you. And Atul, yes.
So, Dr. Scott, I just want to ask you, when would you use a K-wire as opposed to a screw for a child, say less than 10 years, whether a compression screw will affect the growth of the distal humerus? So any preference?
Yep, it's a good question. So since the medial epicondyle is an apophysis and not an epiphysis, meaning it doesn't contribute to longitudinal growth, we would prefer a screw even in a 10-year-old. Now, we will use a K-wire if it has that delayed presentation that we just spoke about, and we're fearful that the screw will blow the piece apart. Right, so we don't want to blow the piece apart, so we may want to use a K-wire then. But even in a 10-year-old, we don't worry about growth because it's just an apophysis, not an epiphysis, if that makes any sense.
So one more question here. Do you recommend excision of the piece in case it's stuck inside the joint for a long time, a delayed presentation with an a stiff elbow? So we are doing an arthrolysis and there's a piece inside.
So it's a great question. So in the delayed presentation with the piece of bone that's been in the joint for months, that is a really hard operation. Like that is like one of the hardest operations because you can't figure out where actually you are, but that piece has to come out, right? And it's often fused or healed, to the olecranon, and you got to take an osteotome and get it out of the joint and then restore some motion. But it is a really, really difficult operation. You probably have more experience than we do because of the delayed
So we've been in trouble. I just wanted to know if you have some different thoughts about it.
No, not really.
All right. Okay. So again, correct me if I'm wrong, but as I heard your lecture, you mentioned a lateral approach, or was it lateral position and medial approach?
Yep. Medial approach, lateral position, or prone position.
Okay.
Yep.
Yeah. And how many times have you found the ulnar nerve also entrapped?
Oh, what? I'm sorry, I missed the question.
Did you get cases where the ulnar nerve was entrapped with the inside the joint when it was reduced?
Yep, for sure, actually. So you can see median nerve, ulnar nerve, or epicondyle. Good point. I should have brought that up.
Right. Okay. Thank you.
Okay. Yeah, exactly. So now we go to the third topic.
Is that me?
Yes.
Yes.
Then.
All right. So we'll do the OCD, Scott, first.
No.
So I have
Yes.
it queued up.
Yep. OCD first, and then trash is afterwards. Kevin's next, then trash.
All right. You see me?
Yes.
Fantastic. All right. 1 second. Get this. All right, there we go. So my charge today is to talk to you about capitellar OCD lesions. This is, you know what that is, Scott? That's actually a Chihuly glass. It looks like an OCD lesion. And for some reason, I'm not advancing. Give me 1 second. There we go. All right, so what is an OCD of the capitellum? It's osteochondritis dissecans, which I think is a very confusing acronym because OCD also stands for osteochondral defect, and an osteochondritis dissecans can lead to an osteochondral defect as well. So it's very confusing. And I think realistically, it should be called avascular necrosis because that's really what it is. So how does this fit in with Panner's disease? And frankly, I'm not sure that it's any different. Panner's disease is avascular necrosis, ages 5 to 11. You tend to see OCD lesions in kids 10 to 16. So it may be the same thing in a different age population. Younger kids tend to recover more so than older kids, so that may affect the difference in the perception of the diseases. It's really an overload of the lateral side of the elbow joint, and it's part of this little league elbow complex. We have, but it's in the US, I don't know how it is in India, but in the US, it's less common now in pitchers. It used to be really common. It's common in places like Japan in pitchers because they don't have pitch counts. And for us, it's most common in gymnasts. I just saw a gymnast today in the office with an OCD lesion. They may have medial collateral ligament laxity because, again, of valgus overload issues. And the blood supply to the capitellum, we know, is limited in children, and this may affect why this area is so vulnerable in valgus overload type situation. This is a schematic of where the vessels are. You see the medial collateral artery posterior and the radial collateral artery, both feeding the epiphysis, but you can see they're not crossing the physis because no vessel is able to cross the physis. And so you lose your interosseous blood supply to the capitellum compared to an adult. So what's happening is really the pothole analogy. And I'm sure you guys have potholes like we have potholes. But what happens is that you erode the underlayment or the bedrock underneath the pavement. And over time, the pavement collapses into that defect. And it's the same thing. OCD lesions or osteochondritis dissecans are really avascular necrosis, and repeated load causes collapse of that bone, which then allows the cartilage to fall into it. So the prevailing wisdom right now is microfracture. I don't know what the current standard of care is in India, but I will tell you in the US, it's mainly microfracture. And Westerman et al. Showed in a meta-analysis that there were 71% of patients were able to return to the same level of sport, and about almost 90% of them returned to some sport activity with arthroscopic debridement, with or without microfracture. And that includes loose body excision, which may be a big part of why these kids hurt. And then the idea is to fill the defect with fibrocartilage, which in my mind is not stable and doesn't replace the primary pathology, which is the bone. So I'm going to take you through a video. See if this plays. And hopefully
this video will cover the Oates procedure for.
So I'm going to. This is a technique of how to do the operation.
Of a 14-year-old boy. The development of the Oates technique for OCD lesions of the capitellum can be traced through Japan.
Let me skip through some of this.
As well as the knee harvest for OCD technique.
So I visited Japan many years ago, and they do a slightly different technique for what's called osteochondral allograft transplantation, or Oates technique, which is called mosaic plasty. And I'll show you what they were doing in Japan and what the difference is with what we're doing now, primarily in the US. So this is an example. This is a case from Japan.
Capitellar OCD. Here you can see the lesion through an anconeus split incision, as well as the knee harvest incision. There are multiple plugs, each of 3.5 millimeters in diameter, that are harvested. And then these matchstick-sized plugs are tamped into the elbow in a mosaic of plugs, hence the term mosaic plasty. In a 2009 JBJS article, they were able to demonstrate.
By the way, you'll notice in that video, if I go back a little bit, the contour of the capitellum is not actually restored. So one of the downsides, I think, of the mosaic plasty, it's very difficult to get the contour back, and you end up with still quite a bit of a bony deficit, even though you've restored some of the cartilage and some of the bone. The reason they take 3.5 millimeter plugs is because they've shown that in the knee, if you take only 3.5 millimeter plugs, the rest will grow in. And so you'll have no deficit later in the knee.
In a 2009 JBJS article, they were able to demonstrate excellent results from this surgical technique, with most patients returning to sport. In May of 2014, I had the privilege of presenting our results and our technique in Japan, described in the Journal of Hand Surgery in 2013, using the single or large plug technique. Lyons et al. Was able to demonstrate results similar to mosaicplasty, with all 11 of their patients returning to their preoperative level of sports.
So that's a very different outcome in the Bobby Traub and Lyons report, where they were able to get all 11 of their patients back to their same level of sport using this Oates technique with a single large plug, which is a much better outcome than you would see with the microfracture technique.
This large or single plug technique. Don Bay published his results in 2020 with 13 patients with good results. MRI is useful in making the diagnosis in this case example. Preoperative MRI demonstrates the lesion on the sagittal, the axial, and the coronal views. After a diagnostic arthroscopy is performed to confirm the presence of the lesion, an ankylosing split incision is used to gain access to the lesion, which can be seen in deep flexion.
And you can see that through a relatively small incision, you get great access to the capitellar defect in this patient.
Using the Arthrex Oates kit, the recipient harvester is used to remove the lesion. All diseased tissue should be removed, and the harvester is malleted into place. Reciprocal turns are used to try to remove the lesion in toto.
Sometimes the lesion does not come out.
Occasionally, the harvester fails to extract the lesion, as can be seen here. In this case, a guide wire is placed down through the harvester. The harvester is then removed, leaving the guide wire in place. An appropriate size drill from the bioteniodesis set, also from Arthrex, can be used to drill out the lesion.
You'll see at the bottom,
A depth of at least 10 millimeters is confirmed, and the guide wire is removed.
at the bottom, you see that subchondral bone is right before you get to the physis.
Attention is then turned towards harvesting the donor plug from the knee. The leg is exsanguinated and the tourniquet is inflated. We prefer a transverse incision on the lateral aspect of the upper third of the patella. The donor site is the uppermost lateral corner of the lateral femoral condyle. Using the donor harvester, we then extract a plug that is 1 millimeter wider than the recipient plug.
The only thing to caution you is that the physis of the knee, of the distal femur, goes right up to the articular surface of the knee. And so when you see the, essentially, you'll see these blood vessels at the very superior aspect or superior margin of the articular surface. Those blood vessels are feeding the physis. You want to stay on the white of the cartilage and you'll be fine in terms of harvesting outside of the physis. If you try to go too high up and go into those blood vessels, you're going to be compromising the physis of the distal femur. So just be careful of that.
Again, using a reciprocal twisting motion to make sure that the plug comes out in one piece. We prefer to backfill the donor site hole with a synthetic bone substitute, making sure to restore the gross bony contour of the knee. The plug is oriented in such a manner that it best reconstructs the contour of the elbow, and then mallet it into position. We prefer to leave the plug just slightly proud, so then it can be tamped down manually using one of these sizing templates.
You want to be really gentle on this to not damage the cartilage.
The final position and contour is inspected multiple times, and any adjustments are made to make sure that we have a nice, flat contour.
You can see the difference in the contour between a mosaicplasty and a single plug. It's a very different operation, and I think creates a much better fit.
Postoperative management includes 2 weeks in a knee immobilizer, 4 weeks in a long arm cast, followed by self-directed range of motion and a hinged elbow brace, with over 90% of patients returning to sports after 6 months.
So let's go over some of the sort of pitfalls and tricks, right? The anconeus split exposure can be a little bit difficult if you're not familiar with it. However, it does give you access to about the bottom half of the, or the dorsal half of the capitellum, maybe 2/3 if you really stretch it. We have done an anterior exposure to do these OCD lesions and an OAT technique, and that's for when you see a very anterior lesion. There are some surgeons who insist on lateral collateral ligament release in order to get better visualization. We have never had to do this. And I think if you can avoid it, certainly less scarring. Some people who do this a lot feel that it doesn't really make any difference. I think if it were my collateral ligament, I'd rather keep it. Some other things are graft contour mismatch. No matter how you remove the plug, when you extract it, it's very difficult to get it completely flat, meaning it will be raised on one corner. You'll be slightly oblique to the articular surface on at least one of your harvests, as much as you try to keep it square. And what you try to do is make sure that you match wherever the harvest, the plug is highest with the highest deficit so that you get a nice contour. And this is really important because you really get one shot at putting in your graft. You want a little bit of graft recession or flat, but you do not want any graft prominence like is shown in the middle picture. That you want to try to get that down if you can. Right? If gentle tamping doesn't bring it down, then the next step is to put a threaded K-wire into the plug and make sure that you take out, you drill your K-wire exactly the length of the whole plug, because you want to remove the bone and the cartilage. You don't want to just remove the cartilage. And then you pull that out and it pops like a champagne cork. So just be careful. Once you have it out, then resect a little bit more along the bottom so that you can actually recess it. Some other tricks from the knee, again, minimize the potential knee morbidity by harvesting as lateral and proximal as possible. However, not too much because you want to avoid the physis. And you want to make an incision large enough to see what you're doing. I don't think that an arthroscopic approach is really helpful because the incision is quite small and you're washing away all your growth factors from your graft and defeats the purpose of having the autograft bone. And if you look on this picture, you can see those blood vessels. That's what you see along the superior and also the lateral margin of the articular surface. And those are the ones you want to avoid to stay out of the physis. In terms of complications, long-term, what about the harvest site morbidity? Long-term complications, so far we don't really know, but no one has reported any significant long-term complications on the longest term that we have, which the longest term study that I saw was 14 years. Delamination of cartilage may be an issue. I've seen one patient who has failed an OATS in terms of having the plug actually fail. Non-union, again, really rare. Elbow instability, not seen. But I have seen in 2 patients recurrence, meaning they developed a secondary OCD lesion after they went back to sports a couple of years later and had to have another OATS procedure. This is the 8 to 14 year follow-up here. And again, all of these 8 patients maintain pain relief and sports participation in these relatively long-term follow-up. And the question is really recurrence a failure, or did we just fail to address the underlying cause? And is valgus overload on immature capitellum, right? If that didn't change, then why would we expect a different outcome? Does age matter? The recurrences I've seen have been in younger patients, not in older patients. And then should all patients get sports technique re-education? That's a big issue, is maybe their kinematics are off when they're throwing the ball or the way they're landing or whatever it is they're doing in gymnastics. And then should all at-risk athletes be trained on proper techniques, and should their activity be limited? Clearly, pitch counts have worked to limit the number of injuries in kids who are pitchers, and that may be an issue for gymnasts, etc. I'm not going to get into this in the interest of time, and I'll stop right there and take questions. Thank you very much.
Thanks, Dan. Thanks for that lovely video. You have 3 questions, a couple of them from Dr. Ruchita, who's asking you, what is an alternate donor site in case the knee is not available? Do you have one?
Yeah, let me go back. Hold on one second. You have, see, I skipped over those slides.
You can just mention it.
Yeah, so here they are.
Okay.
So what are the alternatives? Costal cartilage, iliac crest apophysis, microfracture, which we talked about, synthetics. And I think allograft may be a reasonable thing. I think the question is, we don't know why these things hurt. We don't know why OCD lesions hurt. So it may be that just replacing it with a piece of iliac crest and recreating the bony integrity may be sufficient without having to really reconstruct the articular surface. So there are allografts that are made that you can buy off the shelf. I think iliac crest is probably a reasonable thing. Costal cartilage is probably reasonable. That's about it.
All right. So the next question was, what is your youngest patient where you would offer this procedure? And the last question from Atul was, what is the minimum size of lesion that you would offer the procedure? So age and size.
Right. So the youngest I've operated on is 10. And I think that anyone younger than that, a lot of these will heal on their own. So if you wait long enough, they'll become asymptomatic with time. It's just that a 9-year-old gymnast or an 8-year-old gymnast, they're pretty driven. But it becomes a parental issue. I think all of these at a young age can be managed with activity modification. The other thing you may have to do if there's a loose body, I would definitely get the loose body out. But I think that's probably the minimum age that I would do.
And the size?
And then in terms of size, I think the Oates kit only goes down to 5. So I think anything below that I would not use. And there's a pretty good reason for that. What's that?
No, 5 mm and above.
5 mm is the very, very minimum. And I will tell you, I've never done one less than 7.
Okay. All right. So thanks very much, Dan.
Yep.
Before we move on to the next lecture, Scott, you've got 2 questions. The medial epicondyle torque, do you transpose the ulnar nerve every time you fix it?
Not routinely transpose the ulnar nerve, only if it's subluxating out of the cubital tunnel.
Okay, and do you recommend that we should start doing CT scan for diagnosis of displacement in each epicondylar fracture?
No, I do not. No, I do not. I think you should use your clinical examination or assessment of stability.
Okay.
It's less radiation. It's like the arthrogram exam we spoke about before.
Yeah. Okay. Thank you.
Yeah, if I could add a comment to that.
Sure.
It doesn't really matter how much your displacement is, because if it's a displacement of a muscular avulsion, right, you don't care at all, right? It can be displaced 2 centimeters. It's irrelevant to the patient's outcome. But if it's a 5 millimeter displacement of the ligament, right, 5 millimeter displaced avulsion of the ligament, well, that's very significant. Even probably a 3 millimeter displacement of the ligament is significant. And so Scott's point, for us, it's exam under anesthesia is how we decide whether we're going to fix them or not.
Clinical examination, maybe arthrogram. Dhiren bhai, shall we move on to next talk?
Yes, yeah. The next talk is by Kevin.
I kind of agree with Dan and Scott that I don't think displacement is the key for medial epicondyles. I think it has to do with what they do. You know, if they're overhead athletes, throwing sports, gymnasts, then you're probably going to fix them almost no matter what, because you need that stability to be rigid. If they're not, maybe you don't have to fix it, but you have to use your clinical examination. But once again, I appreciate you guys having me. I am looking forward to my next visit. If you couldn't find me, there's another Where's Waldo game you can play. Lecture. So thinking about this case, this is a 13-year-old female that we treated. She was actually first treated when I was a resident. This was now like 17 years ago. And so she had a both bone forearm fracture after a fall. She had a reduction, she was splinted, and then she came back to clinic and it didn't look good. So what's your treatment algorithm? We'll kind of go through things a little bit. But when you think of the forearm, you think of it as a joint. It is a diarthrodial joint with a membranous component in the middle, and the interosseous membrane imparts stability. So if you think of the forearm as a joint, you're not going to accept a lot of displacement of an articular fracture. So why would you accept that much angulation or displacement in a joint fracture of the forearm joint? So when we evaluate them, we like to know the history. It's usually a fall in the outstretched arm. I don't have any cool videos like Scott does, so I think he sent me one I could have used. I do want to thank Scott for some of the pictures that we have in this talk. Most of the kids that you treat can be treated closed, right? 95% will have a reduction and be managed successfully with casting and wedging, but operative treatment is increasing over time, despite in any sort of outcomes-driven data supporting the increase of operative treatment. I think it is backed by the ease of care. If you have a kid with a both bone forearm fracture that's displaced, if you put Nancy nails in, you don't have to worry about it. But if they're displaced and not looking great on an X-ray, you have to wedge the cast and you get another X-ray, and then have to come back in a week and wedge it again and look at another X-ray and remold the cast. And it becomes much more complicated. But I don't think that should really be the indication for surgery. This is a 10-year-old female who fell from a horse, so an adolescent patient with a troublesome injury, right? Really displaced, almost open, reduced, looked reasonably well aligned, and so managed to heal that way. The good news about a 10-year-old is that she can remodel, and so remodeling can happen, and you can get a fully normal arm with just remodeling. And here's her floor range of motion at the end of it all. So that's a great result. However, what are the limits of closed treatment? And so, surgical treatment has indications. And if you look at this article by plug makers looking at different people's opinions based on literature and experience, like the angulation that you can accept goes down over age, especially in 13 to 15, you have to be pretty close to 10 degrees or less in the proximal third and in the middle third, or the split in the middle third. And then if you do need to fix them, what are your treatment options? You can do a plate versus a rod. You can do a single bone, both bone fixation, open, closed reduction. There are lots of different things you can do. So in children under 10, IM fixation is the treatment of choice. You can limit the surgical exposure. You don't have to open reduce it if you can get it closed reduced. Relatively inexpensive. The costs are a lot less for a single bone fixation. It tends to stabilize the bone that's more significantly out of place, which then helps hold the other bone in place. Though both bone fixation is necessary sometimes. So in this patient, the reduction was maintained with a single ulnar rod on the radius field. We did a retrospective review of our patients. We had 350 patients that had either single or both bone fixation. And our results showed that kids with a single bone fixation were generally younger, had a little bit longer time to surgery, but they were quicker to unite and had a lot decreased OR time compared to the both bone fixation group. So there is some thought to waiting a few weeks. Once it starts to get a little sticky, they can fix one bone without fixing both bones. You don't have to fix them right away. But our parameter for single bone fixation is you fix one bone. I typically fix the radius, Scott fixed the ulna, and then you assess whether the other bone is stable. And if it is, then you can leave it with a well-molded splinter cast. Or if it's not, then you can fix it at the same time. So back to our case, this 13-year-old female underwent intramedullary nail fixation. Unfortunately, her ulna was stabilized, the radius was not. They chose a nail that was too long, and after pounding a lot, they thought that it gave, but they took an X-ray and showed a physeal distraction of about 3 centimeters. So that was a big complication. They used a smaller nail, fixed the physis, put some pins in, got the nails to heal, and they come back 6-8 weeks later, they're healed most of the way, except there's some problems with the ulna. But then there she goes and falls again about 10 weeks out. Has a fracture through the non-union of the ulna and a refracture through the radius with nails that are intact and not really holding the fracture still. So she then underwent Fixation, I think I did this when I was a resident at a PGY4. And took out the screws, put plates in, made it heal. She did well for 2 years, but then she fell again and then refractured at the distal margin, or proximal margin of the plates. So, no matter what you do, you can always have something mess it up for you. And she underwent, I think, 3 more surgeries for multiple fractures. They had plates taken off, plates put back on, refractures happening at the edge of the plate again. But you can choose that. You may not need to use quite a big a plate as we use 15 years ago, but they have smaller, more direct plates that you can use. 2.7 versus 3.5 plates might be better for kids. And you get results like this, like Scott's showing, a kid who had both one forearm fixation. You can even tell which side was operated on. It has such good motion. The other problematic thing that we see is proximal forearm fractures. It's a less common fracture pattern, but they are highly unstable. There's a lot more muscles around it. It's hard to hold the reduction. They're more likely to require operative intervention, and there's less remodeling potential because they're farther away from the face. So we did our own retrospective review on these patients and looking at all these factors: age, angulation, displacement, and see what correlated with this. We found out that based on all of our data collected, that of the 2,000 consecutive forearm fractures we saw, we had about 10% or 15% with proximal third fractures. Most of them had initial reduction attempts, but only about a quarter had ultimate operative intervention for loss of reduction. And comparing the loss of reduction versus the non-loss of reduction group, we saw there were only 2 factors that really played out with multivariable regression. One was age at the time of injury. So kids who were younger had a better result than kids who were older. And anybody with a translation greater than 50% was at risk of loss of alignment. So initial angulation had no part in the treatment of these fractures. And even looking at these, additional reduction attempts were more common in the non-operative group. So they should get a reduction and follow them along. Not all proximal forearm fractures should get fixed. But we came up with a fracture score based on these factors. If it's a score of 1 or 2 or 0 based on your age and displacement of these categories. And if you had a total score of 3 or 4, this is highly predictive of ultimate surgical treatment. So if you have older kids with displaced fractures, you should probably fix them early. The rest of them you can probably watch them. Another problem that we see is something called supination dissociation. This is a complication you see from a volar dislocation of the volar bowing of the radius. That's a rare problem that you see, but when you supinate, you get a DRUJ volar dislocation that you see here. This is probably due to growth and remodeling. The radius does not remodel it quite the same way, but that translation over time, as you grow, the angulation, the absolute displacement increases, even though the angulation does not. And that plays a part in this. This is a 10-year-old kid who had a previous forearm fracture that healed in a malunion, and then a distal radius fracture, which then grew itself completely crooked and ended up in unstable DRUJ. And you see, supination, a completely unstable DRUJ like this, which you often need to see with just looking at the PA of the forearm. Don't look at the wrist, look at the forearm. And you have to get a CT if you want to see the real complex problems associated with this. Our technique is really a volar or dorsal approach at the apex of deformity. And you do a corrective osteotomy until you see stability. This is either a radial opening or closing wedge osteotomy, and this works really well. This is our surgical technique. We made an osteotomy, an opening wedge, put the plate on. They had full stability and good correction of deformity. Unfortunately, this kid was only 10 at the time, and he came back 3 years later with another DRUJ instability problem because he grew crooked again, even though he had fully straightened out with his osteotomy, which we don't understand why kids don't remodel correctly. But so in these kids, don't do a soft tissue surgery, just do a osteotomy. But the real treatment is prevention. You can prevent it affects volar malunion of these fractures, and you prevent the supination dissociation. So forearm fractures in adolescents should be treated carefully. They're different than children under 10, but closed treatment is still an option. IM nail fixation can be performed. You want to keep in mind the size of the bone, the complications with IM fixation. You can see isol distraction. If you have too small a nail, you can lead to non-union, but you can do it. Dr. Kozin and Dr. Zlotolow tend to prefer plate fixation. I do that as well. But if they have an open physis, I think there's enough data supporting the use of intramedullary nails in these patients as long as you treat them appropriately. And complications do happen from any treatment, even closed, open, all the things that we talked about. So be careful when you're fixing these fractures. Thank you for your time.
Thanks, Kevin. A couple of quick questions. One was in proximal radius ulnar fracture, both bones. Have you had instances of cross union or synostosis?
We have not. We've had it for radial neck fractures, when the radial neck unites to the coronoid, but not to a proximal third fracture.
All right.
And those are the openings that you're asking about.
Okay. And the other question was, do you advocate implant removal of the hardware in adolescent fracture fixations, especially plates?
So for flexible nails, we typically do because it's a very small surgery. For plates, I try not to when kids older than 10. And younger kids, if they have a plate, they have so much growth left, the plate's going to become difficult with growth to remove, especially if they have a complicated fracture or, fracture at the edge of the plate. But in older kids, 12, 13, 14-year-olds are close to being done wrong. If they have plate fixation, I will leave it in. I do sometimes with Nancy nails, flexible nails work really well, but if you grow a lot, the nail is sticking out then through a cortex, not through metaphysis, which makes it a weak spot. In older kids who are about done growing, if you use flexible nails, you can actually bury them into the bone, so you don't have to take them out and leave them in forever. And I've done that in a few patients as well, just because I know they're not going to grow enough to cause problems.
Okay, Atul had a question.
So sometimes we get delayed presentation at 2 to 3 weeks. In those cases of forearm fracture, would you prefer to do an open nailing in case you're open to put the IM rods, or would you prefer putting a plate? So child comes in 2 to 3 weeks.
So, a small incision for an open reduction, you can get the bone aligned. You can do it closed sometimes, but if it's bayonet apposition after 3 weeks, you'll never get that. So you make a small incision, you realign the bone, pass the nail through it, and it works just as well as plates do. If you have the right size nail. I think that's the key part, is to put the right size nail in.
All right. Okay.
Yes, we go to the next talk. Then
I'm next. All right.
Yeah.
So I pre-recorded this thinking I might be late, which I was. So let me just play it. It should be 10 minutes. Let me get this going. Okay.
Acronym for the radiographic appearance seem harmless, published in this paper by Peter Waters, James Beatty, and James Kasser. And this really defined this injury. Here's an example from their paper, and you can see that the radiographic appearance really is subtle. But if you look closely, you can see that there's some fragmentation of the radial head, and there is just a subtle subluxation of the radiocapitellar joint. Here again, more subluxation, as is typical over time. And an MRI really shows the injury. You can see this fragment of the anterior radial head with subluxation of the radiocapitellar joint. This was fixed using a single screw in their paper. And what's the problem? Really, the difficulty here is that the pediatric elbow is largely cartilage. And cartilaginous injuries can involve a large piece of the radial neck, radial head, the capitellum, the coronoid, the olecranon. And because we're getting x-rays, we can miss it. X-rays will miss cartilaginous injuries. Here's a few cases just to illustrate the point. Here's an acute injury in a 14-year-old boy who fell onto his left arm. And you can see that if you look, there is a little subluxation of the radiocapitellar joint, and there's an asymmetry to the anterior aspect of the radial head. Here it is a couple weeks later, a little bit more subluxation perhaps, but it certainly is subtle. But it's not so subtle on the MRI. And you can see here again, fragmentation of the anterior part of the radial head, with subluxation of the radiocapitellar joint. This patient was treated with an open reduction external fixation since it was only 2 weeks after injury that we obtained the MRI. It looks like the screws are actually in space, but they are holding that cartilaginous fragment that again cannot be visualized on X-ray. Here's another case with a subacute injury in a 12-year-old girl who fell from the uneven bars doing gymnastics. And again, there's that subtle subluxation of the radiocapitellar joint with a little bit of asymmetry in what you would expect the radial head to look like. 2 weeks later, now we're having really pronounced subluxation, and you can now appreciate that the radial neck and the radial head are involved. But again, it's still pretty subtle and fairly easy for the average orthopedic surgeon to miss. Here's the MRI, and now you can see that there's this plastic deformation of the neck as well as a fracture of the head. Now, we ended up treating this patient initially with tightening of the lateral collateral ligament because we didn't really appreciate what was going on. And this was the first trash lesion that I ever saw. And I wasn't really aware of it. And hopefully you will learn from my mistakes and not make the same mistakes that I made. But after multiple attempts to get the joint reduced, we eventually decided to treat it like a Montasia. And we were actually able to get it, to get the radiocapitellar joint fairly well reduced. And she's done amazingly well. I'm not saying that I would do this again, but I think in a chronic situation where I missed the injury or somebody else missed the injury and it was referred to me, I think this is a reasonable salvage option. And again, she's done very well. Here's case 3, a chronic injury, 14-year-old boy fell while playing soccer 6 weeks ago. Now I've seen several trash lesions by this point, and I'm not going to be taking the fool. So again, here's the subtle subluxation, and here's this fragmentation of the anterior head, and really the whole head is involved at this point. So we opened this up using the Capitellum and placed 3 screws. What we ended up doing was an osteotomy of the anterior part of the neck and reduced it so that it was contacting the capitellum, and then fixed it with these screws. He's done surprisingly well. He does not have full pronation supination by any means, but he's stable to valgus. He does not have posterolateral rotatory instability, and other than lacking 5 degrees of terminal extension and about 10 degrees of terminal flexion, he's regained his full motion and he's pain-free. And I would consider that a good result from a missed trash lesion. They don't always turn out this way. So in summary, I would say do not miss these trash injuries if you can avoid it. We certainly can't change patient factors. We can't make children's cartilage visible on X-ray, but we can be aware of these subtle findings, a subtle subluxation, these little changes to the radial neck and the radial head. And really, I think the gold standard is to get an MRI if there's any suspicion of this trash lesion being. So hopefully we'll all take out the trash and we won't be burned by this injury. Thank you very much.
All right, hopefully I made it on time.
Yes, thank you.
You're welcome.
You did.
Yeah, Sandeep, any question?
No questions. I think we can move.
Okay. Yeah, then we go to the last talk by Scott.
While he's getting that loaded, have you guys seen trash lesions?
Not.
I have not seen.
I've seen quite a bit. I've got a big series.
They're not that common, but they're more common than you think they are.
Yep. Once you start seeing them, you still keep on seeing them.
That's right.
Mind that needs to open up.
Yeah. and they're difficult.
Usually when there's more swelling, there's more swelling in the joint, then if there's an undisplaced elbow fracture on the X-ray, but there's a lot of swelling and just out of proportion to the injury. I think that's when this kind of lesions. And I think
and all of them are osteochondral and need surgery.
Correct.
Yeah, exactly. Yeah, good point.
Okay, so can you see my slides?
No.
Now we are not able to see.
Not yet.
You're not? Okay, give me 1 second. Let me try again.
Yes.
Okay,
Yeah, good to go.
let me just get on slide mode. How's that good?
Yeah, sure.
All right, so,
Yeah, perfect.
I always learned something in a webinar with a bunch of smart people, both in India and in the United States. And thanks for the invitation to all of us. And it was really good to learn a bunch of different stuff. And I'm going to end it with a relatively short presentation about compartment syndrome in kids. And I think if you can remember anything from all the slides that I show you, this is the most important one right here, is the signs and symptoms of compartment syndrome in children are distinctly different than adults. And this is where I think orthopedic surgeons get in trouble, especially if you're not used to taking care of kids. So we all know the P's for adults, the pain, paresthesias, pallor, paralysis, and pulselessness. But what you see in kids, whether it be the upper extremity or the lower extremity, is the 3 A's. So it's the 3 A's and not the 3 P's. And they're increasing analgesia requirements, which is similar to pain, but then they're anxious and they're agitated and they're just inconsolable. And that's a compartment syndrome until you prove it otherwise. And most of the time, you're not going to prove it. You're going to take the patient to the operating room. So I'm going to start with the case example. You can see that Dan and myself and Kevin do the same thing over and over. I think case examples do help take the point home. It's an 18-month-old Amish child, and they cleaned their clothes in these ringers, as you see on the right. And the hand was inadvertently caught in the ringer. And this child came in with pain and it was inconsolable. I can still remember the kid in the waiting area just screaming like there was no tomorrow. Those of us who have kids, there's those fake screams and there's those real screams. This is a real scream. X-rays were totally normal, but here's his presentation. Reluctant to let anybody, including me, touch his right arm. There's a demarcation of distal third you see from the ringer, and it was just tense and swollen. Further examination showed the intrinsic minus posture. He wouldn't even move his digits, and there was ecchymosis along both the dorsal and palmar side. So this is a compartment syndrome. This does not need any compartment measures. This needs nothing other than a knife and needs a surgical operation. So the treatment was, the diagnosis was obviously compartment syndrome and immediate fasciotomy. Whether he ate or drank, it makes no difference. It's an emergent situation. We decided to release the hand, and we'll talk a little bit about incision placements, but 2 dorsal incisions to access both the dorsal and volar interosseous compartment and the adductor muscle, and then a thenar incision and a hypothenar incision, as you see here. Now, there's something fun here. You can say, what's that incision in the middle? That's our carpal tunnel incision. We no longer do that big volar incision that's written in the books. We would prefer a carpal tunnel incision here, and then this ulnar incision. Because ultimately, if you have to come back and do something in the volar compartment, you'd rather have supple skin over the volar compartment. And we'll talk about this when we mention a little bit about Volkmann's ischemia at the very end. So a separate carpal tunnel incision and then an ulnar border incision for fasciotomy of both the volar and dorsal compartments. It's super easy to do, and it's a much better location for an incision than along the volar aspect of the forearm. Here he is at 2 weeks. So here's Stephen at 2 weeks follow-up. You can still see his sutures are healing, but look at his hand. It's back to relatively normal. It's still swollen, but he's incorporating it into activities. So that's the case example. So with reference to compartment syndrome, the diagnosis is really by the history and physical. So it's physical, physical, physical. And the take-home point for children is it's the A's and not the P's. It's the analgesia, anxiety, and they're anxious. That's the symptoms that manifest in compartment syndrome. What about compartment pressures? We don't use them. We really don't use them. I mean, what's the role? I think they're not required for diagnosis for sure. They can be an adjunct in the diagnosis. There's all sorts of different numbers about what's the appropriate pressure, but clearly pressure above 30 millimeters of mercury requires release. The only time we actually will do it is kind of an educational thing. If we have a patient in the operating room with a compartment syndrome prior to fasciotomy, we will sometime measure the pressures with the Stryker system, but sometimes not. With reference to treatment, it's fasciotomy only. You need a scalpel blade. And again, I would encourage you, if you have used this volar incision, to get away from it and move to a more ulnar-based incision. And you'll see why. If you have to come back and do a free muscle, that's a great incision for that. Your volar skin's over your tendon of your gracilis. It's nice and concealed. And just stop doing this volar incision that's written in most textbooks. And the outcome is directly related to the duration of the compartment syndrome. If you don't delay, you end up with Stephen on the left. If you delay a fair amount, you end up with a bad Volkmann's ischemic contracture in the middle. And if you really delay, you end up with a dead arm. So I'm going to end the last couple slides with Volkmann's ischemic contracture, because you see way more than we with the delayed diagnosis in the bone centers. And this is endemic when there are bone centers. The treatment, this is Milan Stevanovic on the right, has really taught me a lot about compartment syndrome. The problem with the compartment syndrome or Volkmann's ischemic contracture is the muscle. The muscle's dead and it's scarred in. The only way to release a Volkmann's ischemic contracture is to release the muscle. It's not a tendinous operation, it's a muscle operation. So again, bone setters can be bad, as you know, and I go to Ethiopia every year and I see a bunch of Volkmann's ischemic contracture. So I'll end with one last example. This is Lydia, a child from Ethiopia who had an injury. I'm not even sure that she had a fracture. She was seen by a bone setter. And this is the classic finding. Her long finger flexors are tight. They put salve on the skin, as you know, so they have changes on the skin, and you can see her finger flexors are tight. Here, her fingers can be extended with her wrist inflection. So this is really an isolated deep compartment Volkmann's ischemic contracture, which we are really, really good at treating. But it's a big operation. So it's an ulnar approach. You need to slide all the muscle off of the ulna. You need to march over to the radius. You need to slide all the muscle off the radius. You need to move the ulnar nerve anterior. You need to see this infarcted type of muscle be released. And sometimes it'll slide anywhere between 5 and 7 centimeters from the medial epicondyle. And you can't stop. You cannot stop the operation until you can do this. And a lot of times there's some residual, either FDS or flexor pollicis longus along the radius that needs to be released. You then put them in a cast like this for about a month. You think they're never going to move. But then we went back to Ethiopia a year later, and here's her left hand. And that's just a win from a very bad situation, secondary to Volkmann's ischemic contracture. So I think the flexor slide is a straightforward operation. It's really good if there's mild and moderate contractures. If it's a severe contracture, like I showed you before, you may have to do a free muscle, but this works for the vast majority of established Volkmann's ischemic contractures. Thank you very much.
Thank you, Scott. That was brilliant. The perfect message in a very short time. A couple of questions here. One was, what is your recommendation?
Can I just make one point, Sandeep?
Sorry?
Can I just make one point?
Okay.
So just one comment, Dr. Scott. I've had a couple of these patients with delayed presentation and Volkmann contracture, and some of the surgeons tried to enthusiastically stretch the muscle under anesthesia by doing serial plasters, and then they fractured the bone. So I think one has to remember that also, despite the ischemic muscle, the bone also is very osteopenic, and one should not try serial plasters to correct these. And that is, I had a bad experience with that child, and we had to fix it in presence of compartment syndrome. So that would be my kind of comment on this. That also look at the bone for osteopenia.
All right.
No, I think it's a real valuable comment. I've actually not seen serial casting tried for these finger flexor tightness. I hope I never see it, but I've never heard of it, but we should avoid it for sure. I mean, I think Milan is right. It's really a muscle problem. And all the stuff about fractional lengthening is not appropriate. You need to release the muscle and let it slide distally.
So there was a question about the necessity of additional web space incisions, Palmer. When do you do those? Do you think we need those?
So was the question to access the palmar ossei? I think you can get them from the back. You just go through the dorsal to get the palmar ones from the back.
All right.
So
you would access them from dorsal incisions itself.
That's correct, for sure. You have to. That's a good point, right? Just take a second. I want to hurry through this. You have to address it. So if it wasn't clear in my talk, we get the palmar from the back. Don't assume that we just get the dorsal. Good point.
Correct. Yeah. And the second point was that in acute decompression fasciotomy and versus muscle slide and muscle resections in chronic compartment, is it still the same ulnar incision?
Yes. For us, it's the incision we use all the time. utilitarian incision for
All right.
release. That's right.
And what is the role of shortening of forearm bones to adjust the length?
Yeah, you're in dire straits. I mean, if you're shortening the forearm bones to achieve finger opening, or you are in a really bad situation. We tend not to shorten the bones if we can avoid it at any cost.
All right.
Do
So
you shorten the bones?
recommend releases rather than shortening bones or fractional lengthening?
That's correct. Do you shorten the bones, Sandeep? Have you ever shortened the bones?
No, I haven't.
No.
Yeah. So I think this was a wonderful webinar on a lot of different topics of the upper limb. And I'm sorry that we were running short of time and we couldn't take many more questions for discussion. I guess we were just crowded with too many talks. Maybe we should cut down next time. So on that note, I thank all the speakers, Dan, Kevin, and Scott, for sparing your valuable time, contributing to the knowledge sharing between POSI and POSNA. And thank you, Dhiren Bhai, for initiating the program, and Atul for sparing your time, and everybody who was tuned in. Thank you very much, and good night.
Thank you. Thanks.
Yeah. Thank you. Bye. Bye. Thank you very much, everyone. Yeah.
Bye, guys.
Thank you. Great being with you.